Acquired aplastic anemia. Definition. It is defined as the presence of pancytopenia in the peripheral blood and a hypocellular marrow in which normal hemopoietic marrow is replaced by fat cells. Abnormal cells are not found either in the peripheral blood or bone marrow. The etiology. First of all, we have the inevitable aplastic anemia. This usually occurs when anyone is exposed to cytotoxic drugs, ionizing radiation, radioactive substances, because these materials are concentrated in the bone marrow, acts on the actively dividing cells, causing aplasia, which is usually reversible. It means recovery is usual once the exposure is stopped. The second type is idiosyncratic aplastic anemia, and this occurs spontaneously after exposure to drugs or virus. The course here is prolonged and the onset unpredictable. Death from deficiency of granulocytes, platelet with failure of supportive measures may occur. Concerning drugs, there is a delay of 2 to 3 months between exposure and the onset. The commonest and the oldest example is the chloramphenicol, others including sulfonamide, the non-steroidal anti-inflammatory drugs, the gold salts, aminosalicylate, and benzene. While after exposure to viruses, there is a delay of 6 to 12 weeks between the exposure and the onset, and the prognosis is usually poor. Example of these viruses is the parvovirus, hepatitis virus, EB virus, means Epstein-Barr virus, and HIV. The overall incidence of acquired aplastic anemia is relatively low, with an approximate incidence in both children and adults in the United States and Europe of 2 to 6 cases per 1 million population per year, while in Asia the incidence is higher. It is as many as 14 cases per million per year reported in Japan. Few words about pathology and pathogenesis. Bone marrow failure may be a consequence of direct cytotoxic effect on hemopoietic stem cells from a drug or chemicals, or it may result from either cell-mediated or antibody-dependent cytotoxicity. There is strong evidence that many cases of idiopathic aplastic anemia are caused by an immune-mediated process, with increased circulating activated T lymphocytes producing cytokines, mainly interferon gamma, that suppress hemopoiesis. Severe aplastic anemia is defined as a condition in which 2 or more cell components have become seriously compromised, with a granulocyte less than 500 per cubic millimeter, platelet less than 20,000 per cubic millimeter, and retic less than 0.2%. Bone marrow aspirate and biopsy show moderately to severe hypocellularity. It means less than 25% of the hemopoietic cells remaining. The other 75% is fatty tissue. Moderate aplasia. 2/3 of the patient may present with moderate aplasia for the first time, in which the granulocyte usually between 500 and 1,500 per cubic millimeter, platelet between 20,000 and 100,000 per cubic millimeter, and retic less than 1%. Bone marrow aspirate and biopsy show 25 to 50% of the hemopoietic cells remaining, but eventually they progress to meet the criteria of severe aplasia. The clinical course either stable, in which the patient is presented with a degree of pancytopenia which is constant for months or years, progressive or fluctuating, presented with small degree of pancytopenia that become profound within months or years. Unstable, the patient may show improvement in the red cell, then show abnormal clone as paroxysmal nocturnal hemoglobinuria, myelodysplastic syndrome, or acute leukemia. The clinical feature in 70% the cause is idiopathic. With a gradual onset, the patient cannot remember whether he was or she was exposed to any offending agent or any infection. Pancytopenia results in increased risk of cardiac failure, infection, bleeding, and fatigue. Anemia will cause pallor, fatigability, weakness, loss of appetite. Thrombocytopenia causes petechiae, purpura, and ecchymosis with bleeding anywhere. Leukopenia lead to infection. Very important, there is no hepatosplenomegaly, no lymphadenopathy. Jaundice may be noticed with post-hepatitis aplasia. Differential diagnosis should be done from leukemia, collagen vascular disorders, and paroxysmal nocturnal hemoglobinuria, usually by doing flow cytometry of the red cell looking for CD48 and CD59 in the red cell, which is very sensitive test. Lastly, it should be differentiated from infection that may respond to specific therapies such as IV immunoglobulin for parvovirus. The lab finding, of course, there is anemia. It means low hemoglobin, low white cell count, and low platelet with elevated cytokines and raised hemoglobin F. And bone marrow biopsy reveal more than 75% of the marrow is replaced by fatty tissue. This slide is a bone marrow which is hypocellular. You can see how this is the white things is fatty tissue, while the cellular element, the blue one or the purple one, the cellular element is very low, less than 25%. Treatment, of course, for surviving, the patient require transfusion including blood, which should be packed cell, leukocyte-free, given every 3 to 4 weeks. Platelet transfusion needed when there is severe aplasia with a count less than 20,000 per cubic millimeter. Here, a prophylactic platelet transfusion should be given. Very important to avoid transfusion from family member because of possible sensitization against non-HLA tissue antigen of the donors. And try to minimize the risk of CMV infection by leukoreduction to prevent alloimmunization. Prophylactic antibiotics should be given when the granulocyte count less than 200 per cubic millimeter. We should cover gram-positive and gram-positive organism in any patient with febrile neutropenia after culturing. If there is no response within 48 to 72 hours, early introduction of antifungal and antiviral is very important when there is persistent fever. Cytokine supports should be given, including granulocyte colony stimulating factor or granulocyte macrophage colony stimulating factor should be considered in a refractory case in order to increase the white cell count. Ongoing study using the L-Thrombobac, which is an oral thrombopoietin mimicking agent, or elmtuzumab, which is injectable thrombopoietin mimicking agent, to be given in refractory cases to increase the platelet count and prevent bleeding. Immune suppressive therapy is very important, especially useful if a matched donor is not available. Here we use either anti-lymphocyte globulin or anti-thymocyte globulin. The first response is usually noticed within 4 months. If no response occurs within 4 to 6 months, another course should be given. Another medication used is the cyclosporine. and this has the advantage to be given orally, and it can be given either alone or with anti-lymphocytoglobulin and anti-thymocytoglobulin, as well as it can be given with methylprednisolone with or without cytokine support. But it has the side effect of hepatic and renal toxicity, which should be checked before starting treatment and every 3 to 6 months. Androgen is of no benefit in acquired aplastic anemia. Splenectomy can be done for those who become resistant to platelet transfusion. Bone marrow transplantation is the treatment of choice if there is an HLA-matched siblings donor, and it is usually very useful for young patients with severe aplasia. The conditioning regime usually use a combination of anti-lymphocytoglobulin, cyclosporine, and cyclophosphamide. The addition of anti-thymocytoglobulin and cyclosporine to the conditioning regimen has resulted in reduction of graft rejection. Unrelated donor probably only can be justified if the donor is a full matched and the patient has failed immune suppressive therapy or as a part of clinical trial. The indication is young age and severe aplasia with a neutrophil less than 200